Good morning, everyone, and welcome to today's meeting. I would like to welcome you all here today. We are very honored to have the opportunity of inviting Professor Chalid Assaf as our guest speaker today. Professor Assaf has been graduated from Free University of Berlin and was trained at Benjamin Franklin Medical School in Berlin and at University of Oxford. In 2003, he was appointed as a specialist at the Dermatology Department. From 2004 to 2008, he was the head of Lymphoma section of Skin Cancer Center Charité. In July 2008, he received his professorship at Charité University Hospital in Berlin. Since January 2009, he is the director of Dermatology Department at Helios Klinikum Krefeld. In addition, he was the president of numerous organizations in Germany and outside Germany. Professor Assaf is the editor of several books and has authored more than 120 articles published in medical and scientific journals. He will speak today about the emerging drugs for cutaneous T-cell lymphoma. Please welcome Professor Assaf.
Thank you very much, Dr. Al-Sayad, for this nice introduction. I really feel prestigious to have a talk in this new and prestigious society of the German Egyptian Society of Research. And of course, I'm glad to present my special topic regarding cutaneous T-cell lymphoma. So today the title is Emerging Drugs in Cutaneous T-cell lymphoma. I will speak initially some general words about cutaneous lymphoma, cutaneous T-cell lymphoma, and have a focus on current novel treatments. And at the end, I will give you an insight regarding potential new drugs which may get entrance into the market and also to the patients. So cutaneous lymphoma at all, it's a rare disease. It's a heterogeneous group of disease which primarily starts in the skin, but it could secondary also involve other organs like lymph nodes or other organs like spleen or liver, which is very rare. The incidence is about 1 case of 100,000 per year. What is very important is that the cutaneous lymphoma have completely different clinical course than the same lymphoma which you find in the lymph node. So they could have the same histology if you compare it primarily in the lymph node and in the skin, but the biology, the prognosis, and also the treatment is usually completely different, especially in the early stage, between primary cutaneous lymphoma and systemic lymphoma. And here you see the frequency of cutaneous lymphoma distributed in the skin. And you see at the first glance that mycosis fungoides is the most common type of cutaneous lymphoma. And therefore, we have also the most data regarding prognosis, regarding treatment, clinical trials. Usually, they all focus on mycosis fungoides and also Sézary syndrome. So they cover about 50% of all cutaneous lymphoma. And the next common T-cell lymphoma, common lymphoma is also T-cell lymphoma. It's called the CD30 positive lymphomas, which include lymphomatoid papulosis and the primary cutaneous anaplastic large cell lymphoma. And in the opposite to the systemic lymphomas, primary cutaneous B-cell lymphomas are rare. So they cover only about 20%. So in the skin, we have the opposite to that, what we find in the lymph node. So in the skin, we have more T-cell lymphomas, about 80% or 75%, and only 25% are B-cell lymphomas. And besides this, we have very rare other types of lymphomas originating from NKT cells or from plasmacytoid dendritic cells. Next step, after knowing which type of cutaneous lymphomas you deal with, is of course, like in all other cancers, to define the clinical stage. And the stage is primarily defined by the skin lesions, where you have the T1, which means you have patches and plaques, less than 10% of the body surface. T1 means patches and papules and plaques, which covers more than 10% of the body surface. And T3 is the tumor stage. So tumor stage means we have tumor nodules, and here you see also that we have a growing to the fat, sometimes also to the muscles, And these patients have a very bad prognosis. So T3 is a tumor stage, and 2-4 is a erythematous stage where the whole skin is covered by the malignant T-cell lymphoma. Here's some clinical pictures, and you see here on the left, upper left, patch stage of mycosis fungoides. You see it's erythematous, sometimes it's a bit scaling, and it doesn't really look on the first glance that this is a malignant disease. And this is the reason why, especially in this stage, you frequently have a delay of the diagnosis, usually at least 3 years. Here you have the T2 stage, where the skin lesions covers more than 10% of the body surface. Here mentioned the T3, the tumor stage. And you see that besides the tumors, you also could have patches and black slag in the early stage. But of course, the most advanced lesion is defining the stage. So if you have already one single tumor, the patient is in the tumor stage. And here you see the erythroderma. Some people call it also formerly the red man syndrome. So the skin is involved more than 80% of the whole body surface. And of course, the next step in the staging after defining the skin stage is to define, like in other cancers, the nodal stage, the visceral stage, and the blood stage. And visceral organ involvement, like liver or spleen involvement, is something which is very, very rare in cutaneous lymphoma. So in the last 25 years, maybe I've seen 3 or 4 cases only. That means also, if you have a patient who has organ involvement, you have always to exclude a secondary systemic lymphoma. So organ involvement is something very unusual. But of course, lymph node involvement is very common. So lymph node is the next extracutaneous involvement typically in cutaneous lymphoma, and which is also important to define the blood involvement, which you can find also in the early stage, and which could play a role also for the choice of treatment. In general, if you see patients with cutaneous lymphoma, especially mycosis fungoides, most of the patients present in the early stage. So more than 70% of the patients of mycosis fungoides present in the early stage, and most of them stay also in the early stage and never develop in advanced stage like tumor stage or organ involvement. Looking to the distribution of the patients regarding the age, and you see most patients are something between 15 years and 18 years. So they are usually middle-aged or older patients. This is important for the choice of treatment because this patient group usually has other disease and has concomitant treatment, which should be regarded when choosing the treatment for the cutaneous lymphoma. Here you see some clinical pictures of early stage. You see here some patches, some scaling. Here you see annual lesions. And here you see some disseminated flat lesions, also resembling clinical dermatosis like a fungal infection. Here you see the histology, which is important, of course, for the diagnosis. And you see at the first glance in the histology that the lymphocytes, the atypical lymphocytes, which are here epidermotropic, they are small. They are looking the same as normal lymphocytes. So you need immunohistology, and sometimes you need also genetic analysis like T-cell receptor gene analysis. Whereas in the black stage, usually it's presented clinically. Easily you suspect that it could be malignant disease, and the histology is also much easier to define than in the early stage. So differential diagnosis we are dealing often with are dermatitis, psoriasis, eczema, or also mycotic infection. And that's the reason, as already mentioned, that the median delay of the early stage diagnosis is more than 3 years. Whereas in the advanced stage disease, it's much easier to diagnose, and of course also the tumor stage, or if you have the rare case that the patient has organ involvement. Coming now, after this introduction, to the treatment. Since I already mentioned that we have big difference between the prognosis of the early stage disease, which is 1A to 2A, so where we have patches and blacks, less than 10% or more than 10%, compared to the tumor stage. We have also a wide range of treatments. On the early stage, usually we are using immune modulatory treatments like phototherapy, UVB or UVA, or combined with psoralen, PUVA, which was first described, interestingly, in Egypt several years ago, or systemic or topical retinoids. So these patients are very good to control in this early stage of the disease. In contrast, it's much more difficult for patients on advanced stage disease, especially if they have tumors or ectoderma or organ involvement. In these patients, we are usually using systemic treatments like besarotin, interferon, and combine it with skin-directed treatments like PUVA or radiation therapy, which is very important in the treatment of cutaneous lymphoma. Or if we need, we use also chemotherapy, but if we use chemotherapy, we use usually single agent chemotherapy like gemcitabine or doxorubicin. And recently approved in the last 3 years, we have monoclonal antibodies like the fusion protein, brentuximab vedotin, which I'll show you in detail, more in detail, or the antibody against the chemokine receptor 4 like Mughal Mulitsuma. So here you see at the first glance part of the German guidelines of treatment of cutaneous lymphoma. You see in the early stage, first line treatment is phototherapy and especially PUVA or UVB treatment. And this is very successful, especially in this early stage, usually patients getting a treatment once daily for 2 to 4 weeks with an increasing dosage of UVA or UVB. And you see in this patient that we have, after 3 to 4 weeks, nearly complete remission of this malignant lymphoma. So cutaneous lymphoma is very well responding to skin-directed treatment like phototherapy or also radiation therapy, especially in its early stage. What about the advanced stage, which is often very difficult to treat and patients usually getting resistance to treatment? And if you look to the prognosis, it's tumor stage 2B. It's dramatically reduced compared to the early stage patients, which most of them never die to the lymphoma itself. But in the tumor stage, patients usually die to the lymphoma or also dying to the treatment which is needed. And the next point I already mentioned, if you look to the advanced stage disease, so treatment is usually not long-lasting. So also if they are responding to the treatment, the median of all treatments of response before you change the treatment is also called time to next treatment, is about 5 months, also including chemotherapy. So after a median of 5 months, in all of these treatments here mentioned, we have to change the treatment because patient is not responding to the treatment or patient is not tolerating the treatment. So that's the next problem. So here have first cuts of our German guidelines, and you see PUVA in combination with interferon or systemic retinoids are the first line of treatment. And in the second line, which we always need in these patients, we have an armamentarium of different treatments like chemotherapy, like radiation therapy, or the newly approved antibody treatments, which I will show you more in detail. So what are the backbones of treatment, in my eyes, of the advanced stage of cutaneous lymphomas? One of them is low-dose total skin irradiation therapy, where you have especially Dr. Al-Sayad really as one of the world-famous experts, and we are very happy to have him in Germany and to have the possibility to cooperate with him, by which we have published several publications which brought progress in the field of cutaneous lymphoma. So we have really to thank you, Dr. Al-Sayad, for this. And so this is a very important backbone of the treatment. Radiation therapy, especially total skin, low-dose total skin irradiation therapy. The next backbone are the 2 newly approved antibodies, One is the CD30 antibody, and one is the antibody against the chemokine receptor for Mulitsuma. And still we are need and use the chemotherapy, and especially single agent chemotherapy as an example like gemcitabine. And I will go now more in detail to these current treatments. So that's a backbone in my eyes, the two monoclonal antibodies, single agent chemotherapy and total skin electron beam therapy. Coming to the monochemia therapy, gemcitabine as an example shows good responses in the advanced stage, and monochemotherapy like gemcitabine is usually better tolerated than combination chemotherapy, which is often used in systemic lymphomas. And you see the patient which we treated in 2009. He was one of my first patients when I arrived in Krefeld. And you see numerous tumor lesions and also numerous ulcers. And these ulcers which you see are already cleaned. So usually these ulcers are super infected by bacterial or mycotic infections. So lesions are usually also very inflamed. Patients has pain. And based on the super infection, it's also smelling, which leads also to really bad, which has a bad impact on his social life. And you see the patient, we treated him with gemcitabine, and after this we gave him low dose maintenance treatment. And you see the pictures after 4 years. So you get after 6 years a complete remission. And by the maintenance treatment, we got him for further 4 years in complete remission and with a very good quality of life, which is also very important. And here we see a recent study of the German cutaneous lymphoma group where we asked if we give just low-dose gemcitabine as a first-line treatment, if it's also working, and it's associated with less side effects. This is just published some weeks ago by Dr. Placiak, who's my co-worker in Krefeld as a first author. You see this multi-center study of 65 patients, and you see response rate is 65%, which is nearly the same as we give the full dose. And if you look to the progression-free survival, it's about 12 months. Still is the same or a bit longer than the original study, where you use more than the double of this dosage. And I think the PFS prolonged because patients are tolerating much better, and you can give longer the treatment, and the patient has a chance to also experience a response to the treatment and not only the side effects. And here you see progression-free survival in blue of the original study published in 2005 by March et al., using about 1,000 milligram per square meter 3 times a month, whereas we're using about 1,000 milligram absolutely and twice a month. And you see in red that progression-free survival is better than if you give the high dose of the treatment. Coming now to the expert field of Dr. Al-Sayed, but I will try to explain it as good as I can. So total radiation therapy, skin electron beam radiation, it's for a long time known that it's very effective for cutaneous lymphoma. However, when I started dermatology at the end of the 90s, patient was giving usually high dose, means something about 30, 40, 45 grays. And what I have seen in my first patient, that I usually got severe side effects, severe disseminated ulceration, superinfections, and patient died due to sepsis. And that was the reason why not only I, but all my colleagues didn't use this treatment because of this severe side effect. And in the last years, colleagues from Copenhagen, like Lena Specht, or Steve Morris from London, or also Dr. Chalid Assaf from the University of Münster, have shown that if you use low-dose treatment, 12 gray, or I will show you also 8 gray as a total dosage of this electron beam therapy, you get a good results and with much less side effects, as shown here in this large study of Steve Morris from London. You see the technique. So it's a very superficial treatment till where the radiation goes to 1 centimeter below the skin, and you can use it for the whole skin, but you can use it also for the hand and feet. And if you look here to the response rate, you see nearly all patients here in blue are responding to the treatment. This is very impressive. We have no treatment, no systemic treatment till now, which shows such a high response rate as total skin irradiation therapy. And most of them are still long-lasting, which you see on the right side. And if you compare the high-dose treatment to the low-dose treatment, you see at the first glance here in red, the low dose, that's the side effects like fatigue, leg edema, dermatitis, skin infections, which often can lead to sepsis, skin blisters, are much reduced in the low-dose total skin electron beam than the high-dose. And that's why it's we have now renaissance of total skin electron beam, and it's a very important backbone in the treatment of cutaneous lymphoma. And here you see a patient with the early stage, and you see the complete response after 4 months in this early stage. And you see also with very good responses here. 2B means tumor stage, 21% of complete remission, 76 partial remission. So you see very good global response in this treatment. That's why we have learned from our colleagues from University of Münster, from Dr. Assaf and Professor Eich, this technique, and we introduced it also in our department several years ago. And here you see our first patient with tumor stage mycosis fungoides. And after total skin, he received 12 grays, complete remission of the tumor stage of mycosis fungoides. And you see further pictures of the same patient. And the colleagues of Professor Eich and Dr. Assaf have also shown that what's very interesting, that if you give only 8 grays in 2 fractions, patients is also very well responding. And meanwhile, using two fractions of 4 gray is the standard procedure in Münster and also in our hospital for treating patients with cutaneous lymphoma. That means just two radiations, and you got very fast, good response, which is also long-lasting and which is really comparable to all the new treatments I will show you in the next slides. Coming now to the recent advances in the approval of the antibodies. The first antibody which was approved for the cutaneous lymphoma was brentuximab vedotin. Brentuximab vedotin is a fusion protein. That means you have a ligand against the CD30 molecule, which is on the surfactant, and it's fused to a toxic substance, like in other fusion proteins, like diphtheria toxins or others. And here the toxic substance is monomethyl auristatin E, which is a potent antitubulin agent. So, you know, when you have mitosis of the tumor cells, we have this tubulin apparatus, and this is destroyed and disturbed by this toxic substance, monomethyl auristatin E. And after this, the cell is getting a cell cycle arrest, and then we'll go to the apoptosis. So this is primary mechanism. And after the cell died, the toxic substance is also still in the lesion, where it can kill other cells which are CD30 negative, like tumor cells which are CD30 negative, but also cells in the tumor microenvironment, like tumor-associated macrophages as an examples, which are also promoting the malignant T cells. So you have several effects by this substance, direct on the CD30 positive malignant cell itself, and indirect by all CD30 negative cells, including the malignant cells and including tumor cells of the tumor microenvironment. So how are the data based on the clinical study? The mycosis fungoides usually shows expression of some single cells in the early stage, but in the advanced stage, nearly all samples of mycosis fungoides show CD30 expression. CD30 is an antibody formerly termed Ki1, which was first described by Harald Steit in 1982 at his time when he was in Kiel. And that's why it was known as Ki1. And then he developed a formalin an antibody which you can use in formalin preparations. Then he called it BER-H2 because he invented this antibody in Berlin. And Harald Stein is a man why I got to the topic of lymphoma itself. I made my PhD in his department, and this time I'm stick to this topic. Coming back to the brentuximab vedotin data. Brentuximab vedotin was approved of the clinical trial which called Alcanza, where the new drug was compared to standard treatment like methotrexate and the retinoid bexarotene, which are already first-line treatments in our national and international guidelines. Patients were included with mycosis fungoides and also patients with primary cutaneous anaplastic large cell lymphoma. And here I will show you the results. And the results were really impressive. You see overall response, which lasts at least 4 months. So this was asked by the FDA, is in the CD30 antibody about 56%, the overall response. Compared to our first-line treatments like methotrexate, which is worldwide used, or bexarotene, it's only 12.5%. So it's nearly 3 times elevated or increase of the overall response using the new CD30 antibody compared to the standard treatment methotrexate or bexarotene. Looking to the complete remission rate, we have about 15.6% complete remissions compared to only 1.6 in the standard treatment. And which is more important, of course, progression-free survival. It's more than 5 times in brentuximab, about 16.7 months compared to 3.5 months in the comparative arm of methotrexate or bexarotene. And what's also very important, of course, the reduction of symptom burden regarding quality of life. We have a reduction of about 30 points, 30%, then something about 10% in the comparative arm. So for the cutaneous lymphoma patient, the approval of this drug was really an important milestone. Here you see in these figures, the overall response, not just by 4 months. You see it's about 67% compared to 20% in the comparative arm. And here you see patients with mycosis fungoides and primary cutaneous aplastic large cell lymphoma. Most patients have a partial response, which is in green. And some of the patients also in the advanced stage, here in blue, have a complete response. And of course, you have more complete response in patients with primary cutaneous anaplastic large cell lymphoma. Whereas in the comparative arm with methotrexate or bexarotene, you see here in yellow, these are patients which have stable disease, and here in green, patients which have partial remission. And just one single patient having a primary cutaneous anaplastic large cell lymphoma received a complete remission in this comparative arm. And here, what I already mentioned, more than 4 times better progression-free survival using brentuximab vedotin compared to the comparative arm of methotrexate or bexarotene. And here the improvement of the quality of life with brentuximab compared to the standard arm. So this was really, as mentioned, a milestone. And the next question for us, which are recently studied in the EORTC, but also in our German National Cutaneous Lymphoma Group, was how much CD30 expression you need for a response in the patient, because in the Alcanza trial, the inclusion criteria was that at least 10% of the tumor cells have to express CD30. But what's about the patients who have less than 10% expression of CD30? Are still responding to this patient or not? And I will show you shortly here. This is just a case presentation, but it's really important. This was nearly negative in CD30 expression in this advanced stage. And here you see a complete remission of this patient receiving brentuximab. So based on this experience of single cases called with CD30 negative, but if you look to histology, there are some single cells, but definitely less than 5%. we were interested to analyze this in a larger group. And here you see the data of the German cutaneous, recent data of the German cutaneous lymphoma group, which have been presented 2 weeks ago in the EORTC meeting in Marseille. And you see the patients included, 2/3 have less than 5% expression of CD30, and 1/3 have below 10% expression of CD30. There are 31 patients, and I will show you the results. They are nearly the same as the patients in the Alcanza trial. So we have overall response about 55%. These patients have less than 10% CD30 expression. And you have also 16% complete remission, which is nearly the same as demonstrated in the Alcanza trial. So patients who have also single cells which are expressed in CD30 have also very good chance to respond to the CD30 antibody. And this is also confirmed by a recently published EORTC trial. Not to forget, all drugs have also adverse events, and one of the major adverse events using brentuximab vedotin is polyneuropathy, which about 85% of the patients are receiving it, and it's less, it's about 70%, but most patients are responding if you reduce the dosage or stop the treatment. And if you look to the 5 years data from the Hodgkin analysis, you see that about 88% of the patients have an improvement of this polyneuropathy. So polyneuropathy is very important. That means you have to ask the patient if they have any signs of polyneuropathy in their fingers, if it's sensoric or motoric. So you have to take care about these side effects. Coming to the next monoclonal antibody, which is here a completely humanized monoclonal antibody, which is against the chemokininoreceptor 4. It's Mulitsuma. Does it play a role? The chemokininoreceptor 4 is expressed on the tumor cells in mycosis fungoides. And what is also important, it is expressed on the T regulatory cells. And you know, T regulatory cells play an important role in the pathogenesis of cancer. And reducing T regulatory cells often increases the tumor response. And this is also one of the major effects of the checkpoint inhibitors, which use in a lot of different types of cancer, is to increase the immune response, and also by this to reduce the T regulatory cells, which are positive for the chemokininoreceptor 4, but also for other checkpoint ligands like PD-1 or CTLA-4. So by this inhibition of the chemokininoreceptor 4, we have two effects. By this we can have a reduction of the malignant cells, and on the second hand we have an increase of the anti-tumor response by depletion of the T regulatory cells. So this is a mechanism. That's why Wilcox called it getting 2 birds with 1 stone. This is a drug Mulitsuma, which is already approved in Japan for the acute T-cell leukemia and for the cutaneous T-cell lymphoma since 2000, and peripheral T-cell lymphoma since 2012 and 2014. And here you see the largest trial at all in cutaneous lymphoma. It's called the Maverick trial, where the Mulitsuma was compared to the HDAC inhibitor vorinostat. And the primary endpoint was progression-free survival. And here you see already the result in red. Mulitsuma is the progression-free survival is more than doubled. It's 7.7 months compared to the comparative arm HDAC inhibitor vorinostat, which is only 3.1 months. So this was the primary endpoint. And if you look to the patients, we have half of the patients had mycosis fungoides and the other half had Sézary syndrome. And you see at the first glance that the response of both mycosis fungoides and Sézary syndrome was much better than compared to the comparative arm using vorinostat. And you see that if you look in the compartments of the response, skin, blood, and lymph node, that the most and best response we have in the blood, and the second best we have in the skin. But of course, all compartments are responding much better using the antibody against the chemoreceptor 4 compared to the comparative arm. And also this drug could show improvement of quality of life using Skindex 29 by Mulitsuma compared to the Voronezumab arm. Here, patient we treated recently in our department in Krefeld. You see the improvement of the infiltration, and you see here, and also of the scaling by this drug after 8 cycles, which are about 2.5 months. And what is very interesting and also confirming the results of the Maverick trial regarding the very good response in the blood is also seen by this patient, is that we have a very fast reduction of the malignant T cell population in the blood in the Sézary patient, which you can see about 90% before treatment, and after treatment, 12%. So this is also a very good biomarker to look in the blood regarding the Mughal response, because the response is occurring much faster in the blood than in the skin. So the blood involvement is a very good biomarker for response to Mulitsuma. That's why I mentioned in the beginning, it's important to look for the blood involvement also in the early stage of the patient with cutaneous lymphoma, which could get good response and improvement, possibly by Mulitsuma. What is the most common side effects of Mulitsuma? It's infusion reactions, rash, and sometimes infection, but we usually just grade 1 to 2, which can be very good managed. And what we have learned in very recent publication is also that the Mulitsuma associated rash is also associated with better response to the drug. So if the patient is getting a rash due to this drug, it's a sign that the patient will have a good response to the treatment. So this rash is also a positive predictive biomarker. So coming to the end, what we have as a perspective for new drugs, where we have phase 1 or phase 3 trials at the moment. And you see we have a lot of drugs. So we have more than 60 trials in cutaneous T-cell lymphoma, focusing molecules on the cell surface like CD25. There's several new drugs which we have in phase 1, phase 2 against Hodgkin's disease, but also about cutaneous T-cell lymphoma, I think, which are really very promising. We have antibodies against, which we have phase 2 study against CD158, which is a KIR3 antibody. It's a natural killer cell molecule, which is often expressed on malignant T cells and CTCL in mycos fungoides, and especially in Sézary syndrome. And we have also targeted therapies, again, proteasome inhibitors, PI3 kinase mTOR inhibitors, JAK inhibitors, BCL2 inhibitors, HDAC inhibitors we have already approved, but maybe there are interesting combination therapy. Also, we have in the phase 2 trial a drug which are MIR inhibitors like MIR-155, which we have now in a phase 2 study. And also drugs which are working epigenetically, like demethylating agents. And of course, we have in the pipelines and also phase 1 and phase 2 study already drugs which are immune modulatory drugs, like the checkpoints inhibitors, PD-L1, CDL4, which are also very interesting. The CD47 molecules, which are expressed in macrophages, which promote malignant cells. It's also called the "don't eat me" signal. And so the most interesting, I will show you just one study, of course, was the trials using the checkpoint inhibitors, because the checkpoint inhibitors, especially as a dermatologist, they really changed the practice in treating patients, especially in patients with malignant melanoma, also patients with cutaneous squamous cell carcinoma, or patients with basal cell carcinoma, and of course in other parts of the oncology like Hodgkin's disease or lung cancer. The checkpoint inhibitors are very successful, and that's why it was also promising for the cutaneous T-cell lymphoma. But we'll see if checkpoint inhibitor works really for everything. So here's the checkpoint inhibitor nivolumab PD-1 antibody used after brentuximab vedotin and allogeneic stem cell autologous stem cell transplant in Hodgkin's disease. And you see nearly all patients are responding. So response rate was 69% in this heavily pretreated patients. And if you look to the blue, we have also a lot of complete remissions and others have partial remissions. And in the field of cutaneous T-cell lymphoma, we are all dreaming once to get such a result in our advanced stage cutaneous T-cell lymphoma patients. And of course, we are always jealous if we see this data in Hodgkin and if we compare it to the data we have in cutaneous T-cell lymphoma. So how does look checkpoint inhibitors in cutaneous T-cell lymphoma? And here I show you already the phase 2 study published by Michael Kodadas from the Stanford group with Young Kim. And you see at the first glance, and for overall response, only 38%. So it's a big difference from the slide we have seen before. But of course, it's also completely different disease. And if you look to the complete remissions, only 2 of 24 patients had a complete remission and 7 of 24 patients had a partial response. What is, of course, interesting, besides that the response rate is not that high as we expected, and also the complete remission rate is not as high as we expected, is that the patient who showed a response had a long-lasting, had an ongoing response, which you show here. So it seems that there is a small group of patients who could respond, and if they respond, it could be long-lasting. That's what we have learned from this trial. But there's another important point which we have to think about using checkpoint inhibitors, especially PD-1 inhibitors, if we are treating T-cell malignancies, is that we have learned in several case reports and also in a small trial that cutaneous T-cell lymphoma could newly develop in patients who are receiving PD-1 antibody due to other cancers. And we have seen in the last years several case reports. We have seen a small trial also in acute T-cell leukemia. And we have experiences also recently shown in a cutaneous T-cell, EORTC cutaneous T-cell lymphoma trial for advanced stage disease, where we got the results in the last months. So there are cases where you have newly development of a cutaneous T-cell lymphoma or T-cell malignancy under PD-1 inhibition. And what could be the reason for this? And the reason could be that you have an acceleration of the T-cell lymphoma by blocking PD-1. Why? The group of Jürgen from Munich could show in 2019, which was in 2018 published in Nature, and here in the review in 2019, published in Transimmunology, could show that PD-1 is in T cells a tumor suppressor molecule, and is an haploinsufficient T cell receptor. So you already have loss of the half of the PD-1 in these T cells, and if you just want to say simply block the other half of the PD-1, you block completely the tumor suppressor, and by this you have an acceleration of the T-cell lymphoma. And that's what you have seen in real life in the single cases of CTCL, in the case reports, but also in the ATL trial published in the Union Journal of Medicine, and also our experience. This could be also the reason for our experience of our EORTC trial. By this, I will come to the end and summarize. Treatment regimens options are limited for patients for advanced stage cutaneous lymphomas where we need it. However, analyzing CTCL pathogenesis and signaling pathways involved in tumorigenesis has allowed the development of monoclonal antibodies that target markers of CTCL, provide treatment options for patients relapsed and also for refractory disease. And we are happy that we have two monoclonal antibodies. It's Mulitsuma and Mulitsuma vedotin, which are approved for the treatment of cutaneous T-cell lymphoma in patients with advanced stage disease and had already systemic treatment. And by this, we hope to go with these drugs to the next step and to improve the response and also the duration of response, hopefully by combination, like radiation therapy, like total skin irradiation therapy. I'm totally convinced that by this combination, we will get a further step. And by this, I thank you very much for your attention. And for these people who still didn't get enough about cutaneous lymphoma, they're invited to take part on the third interdisciplinary symposium, which we'll have on 16th and 17th of December of this year. It's interdisciplinary, so we have, besides the dermatological colleagues from hematology, from pathology, and of course, radiation therapies, we have experts, and one of these experts is, of course, Dr. Chalid Assaf, and we are very happy to have him on board, and by this, to improve and to get forward in the treatment and management of patients with cutaneous lymphoma. So, thank you very much, and I open for questions.